Right, so we will kick things off. Welcome, everybody, and thank you for joining us this afternoon for our webinar, Enhancing the Timing and Family-Centered Nature of Stroke Care, in honor of Stroke Awareness Month and also as part of the celebrations for our After Stroke program's 5th anniversary. Big birthday this year for After Stroke. My name is Emma Gascoigne, and I'm the Volunteer Engagement Coordinator with March of Dimes Canada for the Maritimes. Before I introduce our two presenters, I'd quickly like to go over just a few housekeeping items just to keep us on track today. So the session will be an hour, including time for a Q&A at the end. Please submit any questions for our presenters using the Q&A icon at the bottom of your screen rather than the chat function. So Q&A rather than chat function. If you think of a question for the presenters at any point, just type it into the Q&A. Once we get to the end of the presentation, I'll have a look through the Q&A and I will pose your questions to our speakers. We will be recording this session. We are currently recording this session, and the video will be available to watch on the March of Dimes Canada Ask an Expert YouTube channel. That should be up in the next couple of weeks, so if you would like to review this material or share it with anyone, you will be able to do that via the YouTube channel. Live automated captions have been enabled, so you can click the More button with the three dots on your toolbar at the bottom of Zoom and select to show captions if that's something you would prefer to do. As part of that, you can also choose to adjust your subtitle text size and colors and really kind of curate that experience for your own preferences. If your audio or your video drops, you can try refreshing your browser or feel free to leave and rejoin the webinar using the original link. You'll just be let straight in. You won't be in a waiting room. And finally, slides from this presentation will be shared with everyone attending in the next few days. I know that's usually quite a popular question. So yes, we will be sharing Dr. Cameron's slides. And I will email those out to everybody who has joined most likely tomorrow. All right, so joining us today, we have Dr. Jill Cameron and Karen Jennings with us. Dr. Cameron is a professor and vice chair of research in the Department of Occupational Science and Occupational Therapy at the Rehabilitation Sciences Institute in the Faculty of Medicine at the University of Toronto. Karen is a caregiver to her husband who experienced a stroke at the age of 53 on June 30th, 2025. Since then, she's been navigating recovery alongside him, advocating for support and care. And Karen wanted me to share that she's grateful for the opportunity today to communicate her experience and the caregiver's perspective with everyone on the call. So I will pass it over to you, Dr. Cameron, to get us started.
Wonderful. Thank you for that introduction and welcome. I will get my slides up and running and hopefully, oops, let me get the slideshow started. There we go. So here we are. So again, thank you again for this opportunity to come and speak. Karen and I are presenting together. You're going to see a little bit of back and forth through the session, and then we will both be able to have a conversation with all of you afterwards and answer any questions you might have. So the outline for today's presentation is pretty simple. I always like to start with answering the question, why are we even talking about caregivers today? I'm also going to speak about the caregiving journey and then go towards this idea of family-centered care. And I think through this, I'm asking Karen some very specific questions where she can share her experiences related to these topics. So I was talking earlier with Emma and Karen, and I was the first time I presented. So I've been studying family caregivers to people with stroke since the late 1990s. And in the early days, when I would present at the Canadian Stroke Congress, there'd be about 7 people in the room. So there wasn't a lot of interest or a lot of traction related to family caregivers. So I learned that I needed, as a researcher in this area, to be very clear as to why it is that we should support family members who are providing care to people in the community. So we we are fortunate that in Canada we have something called the General Social Survey. And this survey happens every couple of years, but they've been able to estimate that 1 in 4 adult Canadians are providing care in the community to somebody with a disability. And using our 2024 statistics, that's about 8.7 million individuals. We also know from Janet Fast and colleagues from out in Alberta that the unpaid labor provided by the family caregiver annually saves our healthcare system about $90 billion a year. In the US, that's over $1 trillion. So we know that caregivers are essential to the sustainability of our healthcare system. We also know that they support a whole variety of activities related to medical or rehabilitation care, medication management, performing everyday activities, family responsibilities, social activities, all sorts of things. Family members are providing support. We also know that across caregiving populations, that many caregivers do experience some stress, maybe some burden. They can experience poor mental health, quality of life. Everyday life can be disrupted, as can their work. There are also positive experiences. We don't want to forget about that, but we tend to think about the negative when we want to try and help caregivers. We also know that even though we have wonderful Canadian stroke best practice recommendations, it is still not standard practice to support family caregivers for this important caregiving role. So this is really why I think it's important for us to have this conversation today and why I do the research that I do. So I like to think about when somebody has a stroke, really acute care is the first place they go, and that's really the start of a journey. We know that the acute care stay for somebody with a stroke is about 5 or 6 days, and that's really a very short amount of time as they then learn to live with the stroke that they've had and try to recover. We also know that caregiving crosses many different care environments. So using this image, and I'm coming to you from the University of Toronto. So here we have the Toronto Western Hospital, a well-recognized acute stroke program. This is Toronto Rehab, where people will go for some, further rehabilitation before they go home. And this is a nice home. This probably isn't a Toronto home. Maybe it's, more familiar, more common in your neighborhood. But anyway, these are the three main environments that I'm sort of speaking about. But I don't want us to forget about long-term care or palliative care, because these are two other common situations in the context of stroke. But much of the work I will be talking about will be the journey from acute care to rehab and back to the home. I'm also going to be talking about family caregivers' needs for support. So I wanted to situate this for you. I like to use Cohen's conceptualization of support, and it includes things like emotional support, informational support and education, instrumental support, or things like tangible assistance or training. So they might need help identifying services or filling out forms, or they may need some specific training to help, if, for example, in supportive communication, if the person with stroke has aphasia. The other thing that the support theorists bring to the table is this concept of appraisal. And early on in my research, when speaking with family caregivers, they would often say that they wished that somebody from the healthcare team would speak with them and tell them that the care that they were providing was good and provide them with that positive appraisal or feedback on how they were doing. So anytime I'm talking about support and the need to provide caregivers with support, I'm talking about all of these different dimensions. So the next thing I'm going to talk about, and this is something that I actually developed during my postdoctoral fellowship. I had been invited to be a part of a research team that was going to develop a program. It was called Getting On with the Rest of Your Life Post-Stroke. And it was going to start 6 months after the person had had a stroke and they were back living in the community. And so I found myself saying to the research team that if we want to provide families with education and support 6 months after the stroke has already happened, well, the education would be too late because families were going to already have had to figure these things out. So that meant to me that I was starting to think about this concept of timing and the need to provide the right supports at the right time. So I developed the Timing It Right framework with my mentor during my postdoc, who is Monique Gignac, who's a social psychologist. So, the Timing It Right framework is a comprehensive five-phased approach to support families from the hospital to the home. It emphasizes the timing of support needs across the care continuum, again, with this idea of providing the right supports at the right time. The central premise is that if we could address families' phase specific needs, we could enhance their preparedness, ease transitions across care environments, and minimize negative outcomes from occurring. Those two little fancy things are just QR codes that you could click on to get access to those primary papers. The only thing I want to say here as well is that I'm often in a situation where a healthcare professional would ask me to identify a measure that I could use or that they could use when they're interacting with families so they would know when it would be appropriate to provide them with support. And I've always refused to do that because I think if we take more of a preventative approach, recognize that caregiving can be stressful, we could probably prevent a lot of stress from occurring. So that's sort of the underlying message with the Timing It Right framework. The phases start with the acute event and diagnosis, where the goal really is for the family to understand what happened. Once they understand what's happened, they go into a period of stabilization where now they understand what a stroke is and they want to start thinking more about that. At some point in time, families shift to this phase called preparation, where they are now going to prepare to bring their family member home. And this might occur either in acute care if they're going straight home after acute care or during inpatient rehabilitation. The first phase at home we call the implementation phase. We've also called this the figuring it out phase, where families are trying to take everything that they've learned in an inpatient context and apply it to their home environment, which could be, a farm out in the community. It could be an apartment. So they have to take what they've learned and apply it to their specific context. And once they've kind of figured things out, we felt that they moved into this more of longer term adaptation to living with stroke in the community. And so our central idea is that families have different support needs across these different phases. So now I'm going to stop sharing after I ask these two questions. So I'm going to ask Karen to sort of reflect on her journey as a caregiver. And I want her to kind of walk the audience through, what was the journey like for her, from the first symptoms to where she is today. And also think about the different supports that she received as the caregiver and what sort of supports she would have liked to have received, but didn't have that opportunity. So I'm going to stop sharing so we can let Karen have her say.
Thank you, Jill. So, as mentioned at the beginning from Emma, my husband did have a stroke on June 30th of 2025. He was only 53 years old. It had been a completely ordinary day. There was no warning signs or symptoms until it happened. I found him in the bathroom. And honestly, it was because of the public education and the commercials and the awareness campaigns that I knew what I was seeing and I knew it was an emergency. The paramedics and the stroke team were exceptional. In one of the hardest times of our lives, we were surrounded by people who knew exactly what to do. Their quick actions made an incredible difference to Daryl's outcome, and we will always be grateful for the care he received in those first critical hours. I spent 10 days sleeping in a hospital chair beside him for 24 hours a day. Once the emergency care ended and he was moved to the hospital, I felt responsible for many parts of his daily care. The nurses were incredibly busy, so I felt those responsibilities became mine. I worried about whether he was eating and drinking enough. I helped him shower. I walked with him. I constantly watched for signs that he might choke or even have another stroke. Not only did I become a full time caregiver overnight, I became a full time advocate. while he was still under full-time hospital care. I certainly wasn't prepared for the level of caregiving at such a young age, and I don't think many families are. I learned very quickly that Daryl wouldn't be the only one dealing with the aftermath of stroke. Before the stroke, I was his wife, and after the stroke, I struggle to see myself now as a caregiver instead. I still see myself as a wife doing what's right for her husband, even though I did have to become an advocate, an appointment coordinator, a medication manager, a transportation provider, a communicator, and an emotional support system for all aspects of our life overnight. We eventually left the hospital, but the responsibilities came home with us. Learning to balance everything and rearrange household and financial responsibilities has become just as difficult as managing the stroke itself. We're still trying to find our way down a path we never would have chosen for ourselves without a huge understanding of where that path will lead us. As for supports, there were many supports for us along the way that were incredibly helpful. So, the rehabilitation team, the early supported stroke discharge program, the March of Dimes, Dalhousie students through Dr. Ellen Hickey, they all play an important part in Daryl's recovery. Having access to people who provide education and guidance and encouragement and practical support makes a difference to both of us. I was also eventually able to access therapy for myself, which has been incredibly helpful. But at the same time, it took a long time to access. And I still worry that it will end long before my time and my need for it does. I understand that our healthcare system is stretched, but recovery from stroke doesn't follow a timeline. And neither does the emotional impact on caregivers. I think that it is especially true for caregivers who appear to be coping well on the outside, but are carrying a tremendous amount behind the scenes. One thing I struggled with was that although I felt included in the care plan, there were many times I felt like I was the care plan. Once someone leaves the hospital, so much of their recovery depends on what can realistically be managed at home. I also wasn't prepared for how difficult it could be to advocate on Daryl's behalf. Because of his speech difficulties, communicating with services could be challenging. I often assumed that as his spouse, I would automatically be able to speak on his behalf when needed, but that wasn't the case. Approvals and consent were required directly from Daryl, even though his ability to communicate was limited. It created a great deal of stress because he needed support, and I was trying to help him access it, but there were barriers to having conversations on his behalf. The reality is that all of this happens while we are still trying to work, pay bills, run a household, and keep life moving forward. Many appointments and programs take place during work hours, so supporting Daryl often meant missing work, which created additional stress and financial pressure. Caregivers are trying to support recovery, but we're also managing jobs, finances, responsibilities, and family responsibilities. I also think that strong caregivers are sometimes overlooked. We may look like we have everything under control, but that doesn't mean we aren't struggling. So, in many cases, we are so focused on the person we love that we don't even recognize our own need for support. We don't know what to ask for, and we can feel guilty if we don't enjoy a program that was recommended for us. Sometimes I can feel my life is completely absorbed by Daryl's stroke, and that can be the hardest part to manage. And I'll hand it back to Jill after that.
Thank you so much for that, Karen. I think it's so valuable to hear your experiences. I think it really takes home what it looks like for somebody who is caring for somebody with a stroke. So thank you for that. And we're going to come back to you again and talk a little bit more. You would automatically sort of think, as a healthcare system, maybe we should provide some support interventions for caregivers to people with stroke. And so, I mean, it's a great idea, but I'm going to talk a little bit more about how that is a bit of a challenge. So, Dalton and their colleagues, they conducted a review of reviews. It's called a meta review, where they reviewed 61 systematic reviews of interventions that were developed to support family caregivers. And after, I don't even know, I couldn't find in the article how many total numbers of interventions were included in this review, but really they came back at the end of this article. It's a mixed results. Like they really concluded that there's no one intervention that would address the needs of all these caregivers, and they're really recognizing that all the experiences can be quite different. So that actually makes quite a bit of sense. Like so, if you think about Karen's experiences and her husband's experiences, I think we know that not no two strokes are alike, but also no two caregivers are alike either. So we have these two levels of complexity. So it's kind of how can we actually develop an intervention that's going to support this level of complexity. So here's one study that Elliott and colleagues did, where they basically studied family caregivers for a full year, and they kept measuring their symptoms of depression. Just, it was a mental health study. And so what you see here are four different trajectories, and these are four different patterns of recovery for the caregiver's mental health, across the first year post-stroke. And at the bottom, you see this group, what they called them resilient. I'm not sure that's the best language, but this is a group of caregivers that from emotional perspective, they were doing very well. But they may not need much from an intervention perspective. If we're trying to improve their mental health, it's already pretty good. And then you've got the extreme opposite at the top. We've got this chronic group that are just not adapting well. Their mental health is really not good in that first year as they're caring for somebody with stroke. So this really reminds us that caregivers are not homogenous. They're not this group of individuals that are, ready and able to receive an intervention to help them. We need to do different things for the people in the resilient group versus the people in the chronic group. So that's one way to think about interventions. We also know that caregiver experiences can vary by their sex, gender, and their relationship to the person they're caring for. So in Canada, our Canadian Institutes for Health Research really encourages researchers to think about their research question through a sex and gender lens. So a former PhD student, Christina Kokorelias, was studying family caregiving in the context of dementia and did want to do this deep dive into sex and gender. We also recognize that in Alzheimer's disease and in many other conditions, females or women aren't just wives, they could also be daughters. So what Christina wanted to do was say, okay, I'm going to recognize that it's not just about sex here, but it could also be about relationship. So she interviewed 10 husbands, 10 wives, 10 sons, and 10 daughters, and did this deep dive into the influence of sex and gender on experiences providing care. And the take-home message was that studying sex and gender in this context only was not sufficient because there were interactions with the relationship type. So it's much more complex than just thinking about things being different by men and women, for example. So that was another level of heterogeneity in the caregiver population, and just sort of reminding us that they're complex and not as a uniform group of individuals. The next thing we started to think about, let's say we still went down a path and we developed a program for family caregivers to educate them, to support them, across the care continuum. I then started to say, well, how are we going to get this implemented into this existing models of stroke care? So I had another PhD student, Victorine Singh, basically asked the question, what's it going to take to implement a program for family caregivers into the Ontario stroke system, which was a leading model of stroke care in Canada and in the world. She published three papers from this in 2019 through to 2020. She did a qualitative study where she spoke with 84 individuals, 12 key informants who were leads of medical and stroke programs. She also did focus groups with the rehabilitation, education, and community care leads in each of these regions. And she also interviewed healthcare professionals who were at the front line of providing care to people in acute rehab and community care contexts. And for this study, we did not interview people with stroke or caregivers because we already had. We'd already asked them what needs do they have and how can we support them. And so we already had an intervention in mind. But the purpose of this was to say, okay, if we develop an intervention, what's it going to take for you to use it ultimately in stroke care? So the findings from this study, again, is it's complex. So there were system level factors that would influence our ability to implement a program for family caregivers. There had to be a lot of evidence to show the benefits. There had to be some strategies to integrate the intervention across the care continuum. Collaboration was identified as something that would be really, really important. There was a lot of uncertainty if we're implementing a program, who's going to own it? If we're implementing a program that we want to cross the care continuum, because of course we don't want to just provide something in acute care. We want something that's going to help families with their journey from acute care to rehab in the community. So who owns an intervention like that? And then there was a lot of discussion about regional variations. We were talking earlier, a lot of people are from out east, Nova Scotia, Newfoundland. I'm sitting here in Toronto. I'm from Thunder Bay. So there's so many different regions. So we really would need to think about that. I mean, also at the program level, there's still this need for evidence that the intervention is improving outcomes. But then, who's going to deliver the intervention? Where is it going to sit? Who's going to pay for it? How much time are we going to need? So anytime you want to develop a program and implement it, there's a lot of things to think about. So it's complex on the level of the patient. Actually, that's my next slide. So it's a slide. So really, again, my question is always, how do we support families who have been affected by stroke? So we already know that no two strokes are alike. We know that caregivers are not a homogeneous group. We know that recovery needs are really varied based on the stroke. Ongoing support is not part of routine care, so that's not already there. We also know that the support needs are changing across the care continuum. We know that one size fits all interventions are not going to work. And we also know that interventions are different, very difficult to implement. So where does that leave us? Because we still want to address the needs of families. So then my next thought became, well, maybe we need to revisit how we provide care. So we know that currently our healthcare system should be offered from a patient, person, or client-centered perspective. But there have been some reviews completed that suggest that these models of care are not addressing the needs of families. So again, Christina Cook-Relias, my wonderful PhD student, she wanted to do a review of models of family-centered care that were already out there. So we know that there are models of family-centered care. So what are they doing and can we learn from that? So what she did is she did a review that included 55 articles that described models of family-centered care for pediatric populations, because of course that's where it really has come from. The pediatric population, families want to be included in their children's care. There's also 15 models that came from a variety of adult conditions, including some general unspecified conditions. And we were really kind of surprised that at the end of this review, we came up with some really clear fundamental principles that were associated with family-centered models of care. So in the middle, we learned that most of these models considered care plan and development and implementation that was family-centered. So it already had in the middle a family-centered care plan should be developed and implemented. And to achieve this, you have to consider family context, which is at the top. You have to have collaboration between patients, families, and care providers. There should be some illness-specific education, not only for the person with stroke and the family, but also for healthcare professionals so they understand stroke better, maybe community care practitioners, for example, who are less familiar with stroke, might need some additional training and education. There also would need to be dedicated policies and procedures to actually implement such a model. So the next thing we did, we're doing research in this area now to try and understand this concept. um, a model of family-centered care for stroke. So I think now I'm turning it back to Karen. So I'm going to ask Karen some questions now to really think about how, when she was interacting with the healthcare system, how did they incorporate her into his care? And she already said that she was, navigating services and trying to do a lot of things. But what did that look like for you? Were you collaborated with in the development of his care plan? Did they consider your family context when you were preparing to go home, for example, or when they're allocating home care services? Did you receive any education or training? So I'm going to stop sharing again and let Karen speak.
Um, Thank you, Jill. So overall, I did feel included in Daryl's care, but I felt that that was a necessity from both sides, to be honest. Like, if they didn't take the time with me to educate me, especially with his aphasia and his apraxia, I would never have known how to communicate with my husband. So it was important that I sat through speech therapy appointments and that I felt welcome and able to do that and ask questions because there was a lot of things that I didn't know. I remember, sometimes certain words would come out that I didn't like. And I would say, that's not nice. Don't say that. And it took time for me to understand that Daryl doesn't understand necessarily the words that are coming out either. So if I hadn't have been involved in those processes, I don't think I would have been able to help Daryl get to where he is, because I'm not a professional. I didn't even know before the stroke that someone could lose their ability to speak and say their own name and count to five and cough. Like I just found that out 2 weeks ago. Like when we found out that he couldn't whistle, and the speech therapist asked him to clear his throat, and he couldn't do that. And I thought, I never knew that. So there's just so many things that we're learning. So even though healthcare providers involved me in discussions, they helped answer my questions. They provided educations that helped me understand what was happening and how I could support them. There was still a lot of things that I had to research. I had to look into. There was a lot of vague answers. There was a lot of stroke looks different for everybody. And we can tell you, this, but we can't tell you this. And it leaves a lot of unopened doors. So I think one of the biggest challenges is that the stroke is so unpredictable. And I had no previous experience with stroke or brain injury. So even though people took time to explain things to me, nobody could really tell me what our future was going to look like. And I know every recovery is difficult and every recovery is different, but that was very challenging to navigate. I remember asking the doctor, okay, so Daryl had a stroke. Is this one and done? Like, I don't have to worry about this anymore. And the doctor saying, no, this is, well, when? What? We don't know what caused the first one. So how would I know what to look for to cause the second one? So it's difficult. So I think it's also important to consider family context when developing a care plan because every family has different responsibilities, different work schedules, financial pressures, support systems, and like you said, what works for one family may not work for another. I was very lucky that my work was generous with me, but even the most generous companies eventually start to get frustrated when they want you to do 2 speech therapy appointments every single day. Although that was very necessary for Daryl, it was a very hard choice for me to choose between do I let my employer down or do I let my husband down? Um, I have a lot of financial burden and a lot of financial pressure that can feel equally as challenging as helping Daryl recover from the stroke. So, as a caregiver, I've been really trying to understand Daryl's recovery while also trying to figure out how to manage our home and our finances and my job and my children and all of the other responsibilities that didn't stop because the stroke happened. So, looking back, I appreciate it being included in the conversation about Daryl's care, but I also think it's important to recognize that caregivers are often trying to make sense of a future they never expected and they don't fully understand. So the more healthcare providers can understand the family behind the patient, the better they can support us. And I'll pass it back to you on that.
Wonderful. Thank you for that.
Thank you.
You know, it's interesting in that my father had a stroke. And when he had a stroke, my mother had trained as a nurse. And I remember that she wouldn't tell the healthcare team that she was trained as a nurse because she felt that if they knew that, the expectations for her was going to be a little bit more. So, yeah,
Yes.
it is very interesting. Okay, so I just have a few more slides to wrap up with. Oops, not text, not letting me advance. Oh, there it goes. I have a few more slides to wrap up with, and we're going to open it up to the general Q&A. You can ask both of us questions. So for me, I think there are two take home. If you're going to take home two messages from today, one is that we really do need to remember that acute care or maybe even emergency response, it starts a journey. And so, 6 days in acute care and a few weeks in rehab and then years in the community. So I think it's really important for us to remember that journey and that people need support over a longer term. I remember one project, one of the participants said, 1 year post-stroke, a reality really hit me. I knew now this is what is going to look like because at that point, I think that I remember that one participant thinking about inpatient rehab is going to fix their family member. And of course, that's, not correct. It's helping them to recover, but it's, the effects of stroke may never disappear. So we really need to think about that care continuum perspective and that things are changing across the care continuum and that people need to be continually assessed and reassessed to see how they're doing. I really hope that we can improve the family-centered nature of care because I think that if we just start interacting with the family more from day one, all of these different elements of support that the families need can happen more organically. We don't need to necessarily develop specific programs, or if we do, then they can be for very specific groups of individuals. But I think, care can be much more family centered, and I don't think it would be a huge effort to do that. So those are my take-home messages from today. This is an absolutely shameless plug for a study that is ongoing where we're looking for healthcare professionals to participate in an interview where we want to ask them about what we are talking about today, really how to make stroke care more family-centered. So if you are able and interested, please reach out to us at that email address or phone number below. And so I'm just going to wrap here. I was encouraged to have a commitment slide for a presentation I gave a number of years ago, and I just thought it was brilliant. And it's this idea of, if everybody can kind of reflect on what they've learned today. So with the knowledge I gained today, I will do something. And if you're a healthcare professional, maybe you will speak more with the families. If you are, a caregiver, maybe you'll reflect on that, it's okay to ask for help and it's important to interact with the healthcare team, no matter if you're in acute care rehab or in the community. So I'm going to stop sharing because I think we can go to some Q&A.
We can indeed. Thank you very much, Karen and Dr. Cameron, for such an excellent presentation. We do have a few questions that have been submitted by the audience. So just as a reminder, everyone, if you do have a question that you've not yet submitted, you can enter that using the Q&A button at the bottom of the Zoom screen. And yeah, we'll just get through as many as we can in the time that we have left. And we do have a good amount of time for questions. So starting us off, we had a question from Stefan. Apologies if that is Stephanie and I have mispronounced it. But they said, in stroke recovery, we often talk about patient-centered care, but family-centered care can be harder to apply in real life because every family has different levels of availability, stress, knowledge, emotional readiness. From your research, Dr. Cameron and Karen, from your caregiver experience, what is one practical change that you feel clinicians can make early after a stroke to better include families without overwhelming them? So I don't know if Dr.
Jill,
Cameron, you
you
want to
can
go
start.
first, and or Karen, whoever wants to go first.
Jill can start.
Okay, I'll start. So this is actually a really great question, and I'm actually doing a project right now in long COVID. And this idea of family context is becoming very, it's a very, very interesting discussion about what does that mean and what does that look like. And I think honestly, and I also, when I teach in our OT program, and I would, tell our future occupational therapists if they could do just one thing, just ask the caregiver, how are you doing? Is there anything that I can help you with? And I think that would make a big difference. And I think that but if you are going to ask that question, make sure you don't have 2 minutes in the hallway. Make sure you actually have time to respond to them and then, work with them. And I think that would be one really, really simple change that could be implemented.
And
Karen,
I'll
what
say
about you?
from my perspective, sometimes that question is a very hard one to answer because I don't necessarily know what I need. And I'm trying so hard to be strong all the time that sometimes it feels like I'm admitting that I can't do it. And that's hard too because I tell my husband every day, like, I got your back, like, we're going to get through it. So then on the other side of that apple, I feel like if I'm asking for help, then I'm admitting that I can't do it. So I think sometimes that question needs to be posed even a little differently than what can we do for you and given to us as more of an option of, this is available to you. Would this be something that you're interested in doing? And not everybody is interested in everything. Like I'll say, I got recommended to support group. It's my least favorite thing in the whole entire world, um, because I'm trying so hard to be happy and not to just focus on my own sadness every day. And it's very hard to sit in a room and listen to a lot of other people's very heavy sadness. And sometimes I come home with even the weight of that. But then I feel pressured almost to do it because I think if I turn down opportunities to do things, they're going to think that I don't need it. And then they're not going to be offered to me. So I think sometimes having an option of what would work best for us and knowing that we still are able to choose what works best for us and what doesn't. And just knowing that it's okay if we don't want to do everything that's offered to us.
Yeah.
Yeah.
And I
Great.
think the only other thing I would, so you spoke about your, like, especially early on, I think caregivers they really don't have an idea of what's coming. This is new to them. And I
Yeah.
think, so March of Dimes, you have that peer support that group, that a peer
Yeah.
support program, right? And
Yeah.
sometimes I think about like the peer support, because I think, this concept of insight and where people, and I know even when my dad had a stroke, like we didn't really know, like he had a mild stroke. And I learned very quickly there's no such thing as a mild stroke. So it was, we asked to gain insight into that. And, peers are a great way, if you're offered even a peer, somebody who's been through it and has some knowledge, of practical things might be helpful as well.
Yeah, I really enjoyed programs like Stronger Together, where you could see somebody that had a a version of what Daryl had and their caregivers and how they were dealing with it. I enjoyed that more than just the caregivers side of things because I felt it very heavy. But when it's with Daryl and caregivers, I feel like my focus is can still be redirected to Daryl without necessarily feeling like, oh, this is kind of selfish. I shouldn't, my feelings are very mild in comparison to what Daryl is going through. So I shouldn't be sitting in a room crying, poor me for 2 hours. I should be supporting Daryl. That's a hard thing to adjust to, especially when you're already a strong, independent person going in, and before the stroke happened.
Thank you both. Our next question is from Saoirse, and I love this question. I think this is probably directed more to you, Karen, but how can a caregiver also be a loving spouse? How do you balance those two things, caregiving versus your relationship with your partner?
I really love this question. So I'm often called, and I love to say this too. I say this in every chance I get. I'm often called a role model spouse. I think it's really funny sometimes because I poke a lot of fun at my husband. We have a lot of fun still. But there's some pressure that comes along with that too. But for me, I've never allowed myself to treat Daryl any differently because I think that you can still be happy and the stroke happened. So coming home every day and crying and being miserable isn't going to change anything. So how I deal with Daryl is you're not the victim of the stroke, you're a survivor of a stroke. And I think that is a very different perspective. And I think it's easy to get lost in this victim mentality. But Daryl survived, and he's surviving every single day. And I'm surviving every single day. And I think there's a little bit of fake it till you make it. Like I do think that comes with it, but Daryl's still really smart and Daryl can still do so many things and he can still enjoy a happy, healthy life. And I try to focus really hard on those things. Like, not that therapy was really hard, but that therapy was really great. You did really good when you worked on this. Did you notice that you worked on this for a whole week and now you can say it every single time? So we don't focus on the fact that it took them a week to learn it. We focus on the fact that, holy, you learned it. And now you can say it and you can say it every single time. So I think positivity, positivity is key and adaptability. Like I think you have to be adaptable to your search to your situation. I'm definitely mad that this happened to us so young. I can't pretend that I'm not mad about that, but that's not going to change the outcome. So I focus on the good things. Yeah.
Thanks, Karen. Right, one for you, Dr. Cameron. What does the evidence suggest is the best timing to involve family members in recovery planning, and how can clinicians support families without putting too much pressure on them too soon?
Great question. I think so. When's the best time? I think so. If a family member, and even if you look at the timing it right framework, like I think it kind of does lay this out. And I think, when I remember, so we had a caregiver who, two different caregivers in one of our studies. One received the Let's Talk About Stroke educational resource during acute care, and another one received it in the community. The one who received it in acute care never looked at it again. The one who received it in the community thought it was the best thing ever. So the timing is really important. So the best time I think is to start the conversation not when you're trying to figure out is it a stroke and what is a stroke. Like I don't think that's a time to start talking about recovery. Even the secondary prevention clinics, it just seems early to start talking about those sorts of things. But I think, once I was started to say, once a person, the stabilization phase, families are catching their breath. They're going, okay, they've survived, and now, okay, what's next? And that's a time when you can start to have those conversations, I think. Yeah, I think that would be, and then, all the way through preparation to go home, back in the home, don't forget about them. Like it just keeps going.
Yeah.
Great. So our next question is from someone who isn't the primary caregiver. Their father is the primary caregiver, and their question is really around, seeing a family member caregiving who is struggling, but refuses to acknowledge that. And so really it's a question of how can they encourage that family member, that caregiver, to reach out and talk to someone and try and get some support. Yeah, Karen, Jill, don't know if you have any thoughts on that one.
I'm actually very much looking forward to the answer to this question myself.
So I can start, and Karen, you can help. So number one, I often use the language that caregiving is a team sport. And I think that often, caregivers may not ask for help, and maybe you don't ask. If you're a family member and you think that maybe they could use help, maybe you just do something. And I think that's kind of an approach to take. And I think, there's also it sometimes it takes time for the care. Like there's this concept, and I'm writing a paper on it, like this idea of insight. And when you're early on, you don't really know what it's going to look like a year later or 2 years later, and it takes time for people to get to that place. But until they get to the time where they reach out for support, maybe you just sort of bring in the bring in the troops, bring in the team, get as much sort of help around. Can be just little things, show up, bring a meal. As we've heard from Karen, like she doesn't take time for herself. We know that. She hasn't said it directly, but we're pretty clear she's not taking time for herself. I remember one caregiver said, I haven't go to get my hair cut. Like I haven't been for a haircut. My mother, when she was caring for my father, she ended up with a detached retina. Like people, they're not caregivers. Are not taking care of themselves. So I think just offer as much support as you can. Bring in other team members and see if that helps. And whether or not a father is willing or a caregiver is willing to go get for help on their own, like they'll have to do that on their own. And there will come a time when they realize, yeah, I probably should do that. I don't know if that's helpful. That's my thoughts.
I was going to add to that. Sometimes respecting boundaries can go a really far way. People would often say that to me, like, you're not doing anything for yourself. You don't do what you used to. You're not doing anything for yourself. And I would say, sometimes I work all day. I have a lot on my mind all day. Sometimes what's doing for myself is just coming home and sitting down and being with my husband and being by myself, even though that looks differently than what I did for myself previously. It doesn't necessarily mean that it's not what I need at that time. So I think I often will have people say, "What do you want to do? What 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 do you want?" It's so much pressure. I just want you to just leave me alone. But so that's what I think what I mean by respecting boundaries. I understand that we have to look out for that other person, but sometimes that person's just not ready right that moment. Sometimes we need to revisit that conversation a week down the road or a month down the road. But understand that if they say, I don't want your help right now, that doesn't mean that I never want your help. I just don't want your help right now. Yeah.
Great, thank you both. Our next question, I think, is maybe in response, Karen, to your comments that peer support groups, can be challenging for you. That's not
Mhm.
necessarily kind of the best fit for you in terms of a community-based intervention. So this question is asking, what do each of you feel would be a community-based intervention that could be explored, something else besides peer support groups? Like, what are the other options? What other things do you think could be available within the community that aren't a peer support group?
Education, especially around speech, impairments. I'm not, like I said, I'm not a speech therapist. I've never dealt with a speech issue. I've been with my husband since I was 18 years old, so 32 years. Sometimes my husband will look at me and call me stupid. It's something I never would have put up with in all of my life and never thought that I would ever put up with in all of my life. And learning different ways to cope with those kinds of things and maybe redirect conversations. And is it okay for me to bring attention to the fact that when you say this word, it hurts my feelings, so that he learns to acknowledge when he's saying that word. Like if I never say anything about it, how does he learn? So knowing the right things to do and the right things not to do when dealing with somebody with a speech impairment is very difficult. So I think education. I'm not looking to become a speech therapist by any means, but it's happening naturally. It's what my future is going to look like. How do I encourage and how do I support, um, how do I do all of those things? So yeah, I do think it comes back to I'd rather sit in a group where somebody's teaching me about, this is what can happen with aphasia. This is a timeline for apraxia. This is what it looks like. I would find that more helpful than listening to how other people are dealing, because it's a lot to process sometimes. Like I think, oh, sometimes I listen to other people's stories and I think, oh man, I don't belong. Like I don't belong here because I'm not going home and crying every single day. So how do I not make them feel bad while still expressing myself? That's what makes the support groups so hard. I loved being with support groups with other people with aphasia. I loved learning that and seeing the differences, and learning from those experiences were much more valuable to me.
So my thoughts. So at one point in time, I was presenting some research, and I used to use a buffet as my example. So if you go to a place and they're offering a buffet, everybody in the room is going to take different things from that buffet. And I
Yeah,
sort of think that that's kind of what the supports in the community should look like.
yeah,
Some people will want that support group. Somebody might want a peer support group. Somebody might just want to go and do yoga.
yeah.
I have a colleague who does the time program. It's time, I can't remember what it stands for. It basically exercise. It's a physical therapy approach, and it's exercise for people with stroke in the community. And I remember, we were working on that, and some of the caregivers would come and do the program with them. Some of the caregivers would drop the person off and go and do their own exercise, or go shopping, or go to something else. Like I think there's just like there's no one, program, but I think this idea of a buffet and having different options that are available, and people can just kind of like, this is what I need and this is
Yes,
what I really want, and that's
I
what I'm going
agree.
to go and do, right? But we need lots of options.
Yeah, yeah, I agree. Like maybe support group isn't exactly what I want to do, but like go into water aerobics, that's something I really want to do. That could be something that's beneficial to him. It still introduces me to the community, but it's more positive focused. Yeah.
All right, I think we have time for one more question. And this is kind of is a big question. I feel like it sort of is encapsulating lots of what we've been talking about today. How should stroke systems balance the evidence-based urgency of early rehabilitation planning with the ethical and practical need to assess family readiness, caregiver capacity, and relational dynamics before asking families to become active partners in care? I told you, it's a big one.
So I'll go back to my mom. Like, no one asked her. My dad had a stroke. He's going home. No one asked her. No one assessed her. No one talked to her. They just sent her home. This is my son's now 27. He passed away just a couple of years before he was born. So this is like maybe 30 years ago. This is what it was like. And I think it's still like that. So I've lost the train of thought. Can you just remind me? What's the question again? Sorry.
So how do clinicians kind of strike that balance
Yeah.
between, needing kind of that urgency of getting caregivers involved in rehabilitation planning, but kind of the ethical and practical side of that of like, are they ready? Do they actually have capacity? What are the dynamics in the family? Yeah,
Interesting.
how can we go about trying to achieve that balance?
Yeah, I mean, I may bring in the idea of caregiving as a team sport. So I did a study at one point in time. It was in palliative care. It was an educational intervention for family caregivers to people with palliative care. And I remember a number of families would if they were families were together, and they would designate a family member to come and do that study. So it was a very interesting kind of idea. So I think if we really do think about family context, like we do have to. We just can't sort of say it's all on one person. It might be because that might be the only person available. So it can't just all be on one person. I don't even, I wonder what happens. Like, so there are situations we should, maybe that's your next session is like, how do people who go home with stroke, who don't have any family supports, how do they manage? Right? Like, that's the other side of the coin. But I agree with you. Like, there's some ethical issues being raised here. Like, we don't want to harm. And I don't know if Karen was even asked, are you prepared to take your husband home? Like, probably not so much, but
I was asked, like, do you have stairs going into your house? Do you have a rail on your bathtub? Those kind of things. I didn't feel like it mattered if I was prepared or not because he was coming home. Because our medical system is so stretched and so taxed that my worry became, how do I keep him? How do I make sure that they don't send him home too early? How do I make sure that they give him what they need? Why do I have to shower my husband in the hospital? Why do I have to take full-time responsibility of as my husband while he's still under full-time care because our medical system is in crisis? That I didn't feel like I had a choice. Like I felt like when he gets home, you better get him home. Like that's so no, I definitely see an ethical issue with that. Like I could take the railing off of my tub. Like that was okay. But that didn't mean that I was ready in all aspects. And I wanted to understand that Daryl was ready to come home. Not just that he was coming home because he reached his 9 day quota in the hospital and he reached his 10 day quota in the rehab center and he reached his 8 week quota with the ESSD program. I remember he got released to the early stroke discharge program and I thought, okay, that's great. Daryl's going to spend a long time in this program and he's going to get what he needs. And they come in and they said, we have 6 weeks with Daryl. And I was like, 6 weeks? Like you let him come home and I only have 6 weeks of speech therapy. Where does this lead after that 6 weeks? And once they were gone, who do I go to? Who do I reach out to? So it's not available. They're just like, here you go, take him home. We're going to support you for a few weeks and then see you later. But I didn't know where to go after that. So I do agree that there is some ethical problems with that. Not that I didn't want my husband to come home, because of course I did, but it's scary. It's scary. Yeah.
I'm just going to add one more thought, and this is something that really I think could really help. And I know that in Ontario, when home care services are allocated to somebody who's going home with stroke, the primary focus is the person with stroke, and the allocation of home care services doesn't take into consideration what might help support the family. And I really wish that they would, because I think that's ultimately where we need to go. So if you're allocating services, the person with stroke could use these things to help them. But if you also provided a little bit of respite, or if you
Yep.
also did, something else, like maybe you need a speech language pathologist coming in the home, like just a few more things that could address some of the needs of the family, I think that would be like landmark. So
Agreed.
that's
Yeah.
another. But you're right, Karen, like our healthcare system is stretched. But as
Yes.
I presented on my one of my first slides, like it's $90 billion of unpaid labor contributed by caregivers, over a trillion in the US. Like we can't ignore that. And if
No.
the caregivers are not supported in some ways, you imagine if they worked a role for a day, what would happen? Like anyway, so I'll leave it there, but it's yeah, we need to do better by them. And seminars like this, webinars like this, huge, right? The first talk I gave at a stroke conference, there were 7 people in the room. Now you've got over 300 registrants who are interested in this topic. So we've already moved the needle, but let's keep moving it.
Excellent.
Absolutely. Well, thank you to everyone who joined us for today's webinar. Dr. Cameron, Karen, thank you again for sharing your expertise, your insight, your experience. As a reminder, slides from today's webinar will be shared and the recording of the session will be available to watch on the March of Dimes Canada Ask an Expert YouTube channel in the next couple of weeks. We also have a second webinar in this series for Stroke Awareness Month called Roadmap to Recovery, the Role of Education in Life After Stroke. That's going to be with Sue Verily, who is the Regional Education Coordinator for the Northeastern Ontario Stroke Network. That will be on Monday, June 29th at 1 p.m. Eastern. We'd love to have you join us for that session too. If you've not already registered, there will be a link included in the email that is sent out sharing today's slides. Thank you again for your time, everyone, and have a wonderful rest of your day. Bye.
Thank you, everyone.
Thank
Bye.
you. Thank you.